Good morning, everyone. It's now my pleasure to introduce our first speaker of the day, Dr. Hannah Hazard-Jenkins. She's the Executive Chair and Director of West Virginia University Cancer Institute. Her focus is on expanding regional cancer centers and improving access to care across West Virginia, as well as enhancing research for the rural population. Her work aims to eliminate disparities in cancer outcomes, and she joins us today to discuss the cervical cancer findings in the American Association for Cancer Research Disparities Progress Report. It is an impressive report, and I recommend that everyone on this call take a few minutes to review it when you get a chance. Dr. Hazard-Jenkins was a contributing author on this report, which was published earlier this year. Welcome, Dr. Hazard-Jenkins.
Thank you very much. I appreciate the opportunity to speak to everyone. And I will go ahead and move forward with my slides. So I really don't have any disclosures other than what was already said as being part of the steering committee for this report. And I think we really have to concentrate and hope through this process we'll be able to think through what a cancer disparity, what a problem it is, as well as some of the contributing factors. Some areas where we've made some progress, because it can't always be negative or doom and gloom. And then ultimately, somewhat of a call to action, much in the line of what everybody has already said about trying to eliminate cervical cancer within our lifetime. So I think one of the things that's important to understand is that disparities just in general, when it comes to cancer care, is truly a public health challenge, if not somewhat of a public health crisis. And in looking at this slide taken from the AACR report, you can see that there are populations, racial and ethnic populations, that have higher overall incidence, higher overall death rates, significantly higher mortality rates. And these fall in line with both racial and ethnic minorities and populations, but also rural counties, which is obviously where I live. And then populations like the LGBTQ plus population, where we're really not paying as much of attention or communicating effectively with them. And the three real big areas where these disparities are in screening, treatment, and then once they've made it, through the active survivorship, then into long-term survivorship. And you'll note here that that in 2021, only 64% of the eligible Asian and individuals were up to date in their USP STF recommended cervical cancer screening guidelines. And that's in comparison to 78% of white individuals. And so the disparities are already sort of being established when we talk about this. So if we talk about cervical cancer disparities in general, there are about 2 million new cancers, not cervical cancers, diagnosed, estimated in 24, as well as about 611,000 deaths from that disease. There are areas where the ethnic and racial minorities are disproportionately carrying some of that burden, rural residents, people living in poverty. But there is some important and accomplishments that have happened in this period of time. So from 1991 to 2020, there's been a 33% reduction in the overall cancer death rate, which is a pretty astounding fact. And there's a narrowing disparities in overall cancer death rates between the white versus the Black population, 33% in 1990 and 11.3% in 2020. So we are making progress, and that progress needs to continue. If you look at cervical cancer in general, about 13,000 new cancers. These are stats and figures you all know quite well, 4,300 deaths. The incident rate actually decreased 50% between the mid-70s and 2000s, but the mortality rates have decreased in more than half, with some caveats. And so if you look here at all site cancers in the top row and comparing different subsets, if you look specifically at cervical cancer, the population compared to white, there is an increased incidence as well as mortality rate compared to the white population for most of these categories. And if we blow that up just a little bit, that incidence are higher among the American Indians and Alaskan Natives, as well as Hispanic patient population as compared to the white population. And so in some of these, I always find fascinating, the incident rate is higher, but the mortality rate is even higher. So it's not just about finding it, it's also about how we're treating it. And we'll talk through that a little bit later. On the right side of your screen looks at the difference in the ratios of different subtypes of cervical cancer. And again, you can see these ratios vary based on based on ethnic and racial minorities. So why do cancer disparities exist? Well, this is clearly not an easy question to answer and has innumerable facets to it. But you can see from these graphics, there is an element of racial discrimination and segregation, as well as a lot of our structural inequities and social injustices. But if you look at the drivers of health, those main components, socioeconomic, so where people live, how well they're educated, some unique biologic factors, and we'll talk about that in a few minutes, psychosocial, clinical, environmental, behavioral, what makes us make the decisions that we make versus not. And you look at how it plays into the cancer continuum from development to all the way to detection and survivorship. And then how does that interplay with the research component? How do we educate? Who are our researchers? How are we expanding and diversifying that workforce? And all of those come together to really talk and magnify or potentially magnify some adverse health outcomes. If you look at some of the disparity burdens of preventable risk factors, such as tobacco use, diet, physical inactivity, alcohol use, they really start somewhat in the core of this, as well as then expanding out to our inequities of our living environments, lack of green space, sidewalks, safety in your neighborhood. Can you get out and walk? Are you inhibited by the lack of green space, lack of sidewalk, or because you don't feel safe being out sort of walking? And then how our institutional environments contribute and maybe even suppress some of the changes that we're able to make in order to avoid and to reverse some of this. So we talk about inequities specifically in healthcare. There are really kind of 5 A's that are highlighted here. The first is affordability. We talk about the uninsured patient population quite a bit, and certainly somebody diagnosed with a stage 1 cancer is 2.5 times more likely to die if they are uninsured compared to the privately insured. I do put a caveat in here that I think we need to also focus on the underinsured. If you look at my state of West Virginia, we embrace the Affordable Care Act, and on paper, the vast majority of the population has insurance. But if your deductible is half of your yearly income, the question really is, are you insured or not? And so we have to think about, what does that affordability look like? What's available to people? What is the complexity of the cancer services that are available? How accessible is it? Are you within a certain distance that makes it a reasonable thing to go get your cancer care? And how well are we making accommodations for unique populations, whether that's physical barriers, whether or not that is communication barriers? Those become really quite important. And then how acceptable is it? And how accepting are we of others? We think about technology as sort of the great equalizer. And I mean, it has certainly helped, but it's as always, it's not the only answer. And so we have the promise of artificial intelligence, which is definitely something that we all talk about it. But the problem is what is the data that is being used to develop these decisions on AI platforms? Are there racial and ethnic diversity associated with this? And so the data, what you get out is only as good as the data that you put in. The same is true for liquid biopsies. So if these tests help to detect multiple cancers, prevent harm, overcome any structural barriers, but again, if the drawbacks and the potential problem is where's that data coming from? What percentage of this come from cultures and locations that aren't well represented? And the same thing is true for digital health. What are those structural barriers? What's acceptable? In my state, it's difficult to do telemedicine because people live in we call them hollers, sorry, but in the holler. So in order to use your digital platform, you have to drive to the top of the mountain. And that's a definite barrier to participating in that kind of medicine. There's a real lack of diversity in basic research models. When you look at cell lines, it's important to understand where those cell lines come from. If you see most of the cellular panels at the NCI, 95% of them are derived from non-Hispanic white patients. If you look at the COSMIC database, greater than 68% of those cell lines are from non-Latino white patients, and only 5.5 of them were derived from anyone with African ancestry. And so when you look at these samples, there's really a lack of data. And so when we make decisions about treatments, we're making those decisions based on research that's done from tissue cell lines that lack the diversity that our population has. And those populations that are probably at greatest risk for these disparities are certain ancestry or ethnic origins, anybody who lacks adequate healthcare coverage, people with disability, older, incarcerated, and there are a whole host of them. And that becomes really important because we're making decisions on patients' treatment and that result in outcomes that are based on data that is from a very narrow window of perspective. So in cervical cancer, what are some of those contributing factors? And you can kind of break them down into screening, prevention, and then treatment. And so not new to anyone here, the importance of screening is to take out what is a precancerous lesion to prevent the eventual progression ultimately to metastatic disease. And I'll point out that the AACR use the USPSTF guidelines, and those are listed here. Again, nothing anyone doesn't know. In an interesting article that was published in the JAMA network, it looked at the Health Information National Trend Survey. And so looking particularly at people's knowledge about HPV, their awareness of vaccinations, and then ultimately about their knowledge of HPV and causing cancer. They did some stratifications by race, ethnicity, as well as educational attainment. And there are about 16,000 participants. Mean age was 58. And you can see the ethnic and racial breakdown of this. What's really kind of fascinating is if you look at HPV awareness, only 40% of people who have less than a high school education are even aware of HPV. And you compare that to a stark difference that's nearly 73% of those that have a college education or higher. And if you look, the Asian population has the least knowledge versus the white population. As far as the awareness of HPV vaccination, just in general, those less than high school, only 35% really had a knowledge about HPV vaccination. But 75% with a college education or more were aware of it. Again, Asian population with the least knowledge compared to the white population. And then finally, HPV causing cancer. So better recognition in the less than high school population and better recognition in the college education or higher. What I found completely fascinating about this is there was better knowledge that HPV causes head and neck cancer than it did and knowledge that it causes cervical cancer. And when you look at the cancers, the individuals that are eligible for screening, for cervical cancer screening, and you break it down race and ethnicity versus place of residence, you can see some of these stark variations in those that are getting screened versus those that are not getting screened. If you look at income, Those that are well below the federal poverty level have a much lower screening rate compared to those that are well above the federal poverty level. College education versus less than high school is a pretty stark difference as well. And so you're starting to play out that the socioeconomic, our environment, where we live, our place that we live really does influence our knowledge base, which translates into the actions that we take. So from a cervical cancer prevention, this is an audience that needs no knowledge about this, but we can really probably prevent more than about 90% of the HPV-related cancers. And these are just the standard recommendations, but worldwide, I believe it's about 250,000 HPV-related cancers each year, and that's a substantial number that we could be preventing. The National Cancer Center for Health Statistics actually broke down the HPV vaccination based on age, and then the gender assigned at birth, as well as ethnicity. And you can see here that the total rate is about 38-39%, and that it is highest in women and girls 15 to 17, and that are white, non-Hispanic. If you look at insurance, those that are privately insured have a much higher vaccination rate than those that are uninsured. Those that have a higher educational degree, whether it's associates and higher, have a higher vaccination rate than those that have high school or less. And then clearly, where you sit relative to the federal poverty line also influences the vaccination rates across the country. And then lastly, where you live, it's urban versus metropolitan versus rural. In this case, a large central metropolitan area, a little bit smaller than the fringe, probably reflective of the federal poverty line where you are in the sort of fringe areas of the metropolitan, but the non-metropolitan areas have the worst vaccination rate when it comes to cervical cancer prevention. So when you talk about cancer treatment and cervical cancer treatment, these are sort of the pillars of that treatment. Surgery, which is as old as time, radiotherapy, and then all the way up through immunotherapy and molecular targeted therapies, which really started in the 1990s. When we talk about surgical treatment, these are just some general disparities in the United States when it comes to cervical cancer based off of race, ethnicity, and rurality. In a study looking at the disparities in refusing surgery for gynecologic cancers, the authors looked at the NCDB from 2004 to 17. There are about almost 800,000 women. Now, I recognize it's ovarian as well as cervical and uterine cancer, but they looked at like who refused surgery. And it was clearly the older population. The average age for refusal was almost 2 decades higher. Uninsured, Black, and then those that have Medicaid coverage as opposed to private insurance, lower high school or lower school education, as well as community hospitals, people being treated in community hospitals, had a higher refusal rate. Interestingly, they noted that over the last 9 years or so, that refusal rate has increased annually by about 1.4%. So it's, in some cases, it's a refusal of surgery. It's the type of surgery that's offered. I think the way we communicate with patients should vary based on meeting them in their place and in their space. And if we don't talk in the right way, we will struggle to get people to understand the magnitude and the need for their interventions. This is a this is a study that looked at the use of radiation, and in particular brachyradiation therapy. So they calculated the rates by race, and the Native Hawaiian and other Pacific Islanders were much less likely to receive brachytherapy for endometrial cancer, as were Black women. And the factors that were associated with not receiving brachytherapy often were because of community cancer centers, which is where they're being treated, and then less access to these more advanced radiation techniques. So in the use of chemotherapy, just in general, chemotherapy is used intermittently, or not intermittently, that's unfair, but there is a divide and a disparity associated with that. There are disparities in clinical trials as well. Clinical trials have sort of been thought of as the great equalizer, with a knowledge that those that enter into a clinical trial really don't have the disparities of outcomes as those that do not. But there are clear barriers to that: patient barriers, physician barriers, and then institutional barriers. What is available out there in the communities that probably need it the most, and what the lack of resources are. And then some solutions associated with that. You know, in our area and in most, transportation becomes one of the biggest barriers to participation in clinical trial. But there are some areas of progress. So since 1991, the CDC's Breast and Cervical Cancer Early Detection Program has provided 16 million breast and cervical exams for women and that are on low income. And I think that's a program that is astounding. And you'll notice that the mortality rate for cervical cancer has declined 8 times faster than for Hispanic women compared to non-Hispanic women, which is also, you know, a nice accomplishment and a definite area of progress. When you look at the screening rates for cervical cancer, again, those the mortality ratios, my apologies, those are also tending to come closer and closer together. The NCI has also started to focus on some of the contributing factors that we've talked about in disparities, which result in these outcome disparities. So since in 2010, there was one research grant that focused on food insecurities, housing instability. It's up to a whopping 7 in 2021, but I think we're beginning to understand that the simplicity of you have a disease, you need to be treated is really insufficient when we address this. And then if you look at the literature, interventions that address some of the social drivers of health, when you address some of them, you can increase those the screening rates by about 8.4%. So our progress in clinical trials is similar. Lots of national intention to this. The NIH has a Clinical Trial Diversity Act that was passed last year that aims to enhance the inclusion of women as well as racially and ethnically diverse individuals in the NIH-funded trials. And I think really important, it's noted that if you offer, in this case, Black patients participation in clinical trials, their rate of acceptance is comparable to whites. So that the myth that they won't participate is really wrong. And in fact, when you really talk about the magnitude of the impact, both for the patient itself as well as the generations to come, most patients, no matter race, ethnicity, rural versus non-rural, really understand that they're contributing not only to their own healthcare, but to that of others in the next generation. So somewhat of a call to action, again, a refresher of those that experience the greatest disparities on the right, but we really need to focus on that interconnectedness and the contributors for the cancer disparities. What are our structural drivers? What are our social drivers? Our ancestry, our ethnicity, how do those all interplay in order to help us understand and then to really mitigate a lot of these outcome disparities that we're seeing in cancer in general, but in particular in cervical cancer. And so there is no one solution. We all know that. And it really is attacking this from innumerable directions: education, resources, transportation, research and cell lines that more adequately reflect the population of the United States. With that, I thank you for your attention. You know, addressing our cancer disparities, we have to do that together, and it ranges from federal funding and policymakers to our communities, which are invaluable in helping us understand where those barriers are and how we can gain trust. The world moves at the speed of trust, and if we don't have trust, then we won't make any gain. So I very much appreciate your attention. I'm happy to answer any questions.
Thank you, Dr. Hazard. We have a couple questions that have come through the Q&A. So the first of those was, do the rates reflect adjustments for prevalence of hysterectomy?
So yes, that graph that I showed earlier does adjust for for prevalence of hysterectomy. Yes, that's a great question.
The second question is, are there disparities for those who are insured and have a diagnosis with cervical cancer and refuse surgery? And second to that is, curious if those who have insurance but the cost is too high to have surgery.
So honestly, I think those are great questions. I don't remember and recall that paper in particular addressed either one of those, but I do think you bring up great points. There are always confounding factors in any statistic. Again, I'll get back to the underinsured because I think that's a little bit what you're talking about in that second part of that question. And I do think that, at least I'm a breast surgeon, so in my practice, there are lots of decisions that are made based off of cost and what is feasible. The financial toxicity associated with cancer treatment, diagnosis and treatment is way under discussed. And I think it's a great question that you asked.
We have another question about, is there any progress in disaggregating API cancer statistics from being grouped as Asian? For example, Southeast Asians have a much higher rate of cancer incidence than other Asians, which dilutes the actual incidence in the SCA population.
Yeah,
Can you speak to that?
Oh yeah, it's a great question. And there, when we were building this report, that was one of the things that was a good topic of discussion. And there is a call in that AACR report to start disaggregating because you are really grouping together and not being able to tell the full story. So there is a particular awareness, certainly on the part of the AACR, but others, of advocating for disaggregating the data for that very reason.
Did the report address geographic disparities in cervical cancer screening?
So in the AACR report, there really wasn't anything specific that I recall about those. The areas, southern, southeast of the United States does tend to have, lower screening rates, but no, not specifically, regions within the US.
And this comes to us through the Q&A. I'm a cytotechnologist, and I've seen noticeable difference among pathologists when they call a case cancer or not. Sometimes patients get aggressive procedures that they may not need. Is there any plan to put all pathologists on the same page regarding their approach to diagnosis and the stage of abnormality?
Yeah.
And I'll add to that, do you think the social determinants of health that affect the patient also affect that call of how you might triage?
So that's a good question on top of that. I do think, so the answer that people are starting to talk about, I think, in the general, is the use of AI and how AI can look at a pathology slide, and make a call and help pathologists with that. So that would start to standardize. Again, I put out the caution, that what data goes into AI to build the algorithms is not necessarily diverse. And I don't mean just diverse in the sense of, racial and ethnic, but we have to be just cognizant of what that data is. But there is a lot of discussion in all of the pathologists, like cancer versus no cancer, and standardization through AI to some degree. Yeah, so I think that's probably the way, just with the asterisk that, we have to understand what data is being used to build the algorithms.
We do have a couple questions about the data. So for your presentation, when you say screening, are you referring to Pap test screening, or are you referring to primary HPV screening or co-testing, or is there a difference in the way the data is collected so we can know?
Yeah, so mostly I was talking about Pap screening.
And do you have any disaggregating data similarly for Black populations as I'm going to say it, I hope I say this right, Afro-Caribbean populations may also have different rates as well?
Yeah, that's exactly the same point. There's a call for disaggregating that data. There's also information and data out there. If you look at the genetics of somebody that that self-reports Black versus white, and then you look at their their genetics, you can also start to determine, are they Caribbean versus West Africa, East Africa? And in the breast cancer world, it actually makes a big difference when you talk about triple negative breast cancer, East African versus West African. So again, these big, broad categories are really very superficial. And with our knowledge of the molecular and the genetics, we are starting to think in that direction, but we also need to start working on when we do big reports and when we start to inform our communities, we need the disaggregated data.
And then last, before we let you go and get back to work, back to your day job, we want to ask, what would you consider to be some of the most best or promising practices in the cervical cancer space to help us overcome some of these disparities? Any words of wisdom?
I mean, I think so. There's a little. It's a great question. So for me personally, I think there is a lot of work that we need to do in communication and trust building. If you learn to understand what your community values and how they respond to communications, you'll gain greater trust and you'll gain greater inroads in that respect. I think the self-testing has obviously has a ton of potential in that respect. The work of the MCEDs that are coming out, which are the multi-cancer early detection blood-based tests, they are on the horizon. They have the potential for greatness, but there has to be some very conscientious thought process behind it and how we implement them. I read somewhere at some point their knowledge and wisdom are not the same. So we have to be wise enough to be able to implement appropriately the knowledge that we get from some of these tests. My fear is MCEDs will widen the disparities when I think the intent is to narrow the disparities. And part of that is, the narrowing intent is because it's a blood test, you don't need a special machine. But the widening is, if you are underinsured and get a positive test, what next? And most cancers don't have the luxury of the BCCSP program.
So thank you very much for joining us today. Really appreciate it. I will shamelessly plug, if you want to help us as the roundtable contribute to some of what Dr. Hazard has said about building trust and really looking at the messages that we send out. We encourage you to join us for our session 1 of Roundtable Talk, where we're looking at specific deliverables, how those deliverables are needed, who needs those deliverables, and then audiences and the messages that they need. And then Dr. Hazard, I have to say it's definitely something that we try to carry on here at the Roundtable, where we add wisdom to knowledge, and that creates understanding. So we thank you for being here, and we look forward to getting those rates up to 90, 90, 90, where we need to be to get to elimination. Thank you.
Thank you so much for the opportunity. Have a great day. Thank you.